Hello, my name is Jaffna Cox. I'm a cardiologist from Canada who's a professor of medicine and of community health and epidemiology. And I've been asked to speak to you today about oral anticoagulants and whether they're safe and effective for use in the elderly patients, managing a damsel in distress. These are my disclosures. I have held grants from Bayer. I've given talks, sat on advisory boards, or received honoraria from all of the companies who manufacture the non-BKA oral anticoagulants, or what I will call the NOACs. I'm also a member of our National Atrial Fibrillation Guidelines Primary Panel, and I'm also a member of the Heart and Stroke Foundation of Canada's Stroke Prevention Guidelines Primary Panel. This is the agenda for today. I'm going to touch on the epidemiology of atrial fibrillation, specifically the projected growth in patients with the disease, examine the associations between age, atrial fibrillation, and stroke, present to you some of the historical trends in the use of oral anticoagulation for atrial fibrillation in the elderly patient, discuss the benefits and risks of the non-BKA anticoagulants, or NOACs, in the elderly, address the appropriate anticoagulant use in the elderly, and then wrap up. Now, as you all know, atrial fibrillation is the most common sustained arrhythmia, and the statistic that one typically hears is that it affects about 1 to 2% of the population overall, although this figure is mostly based on American statistics that are somewhat dated. There are more recent estimates that suggest that the population prevalence may be as high as 2 to even 3.5%, at least in the United States and Europe. These are some of the projections, and it depends on the study. Whichever one you take a look at, what one sees is increasing numbers of patients over the next generation who are going to have atrial fibrillation. And these findings are similar in Europe as well. So the number of people with atrial fibrillation, according to these projections, are at least going to double and possibly triple over the course of the next 30 years. When one takes a look at incidence, the incidence of atrial fibrillation is very low in patients under the age of 55 years. But then with each decade of life beyond 55 years, the incidence begins to double. It's always more common in men than it is in females. And by one estimate, 1 in 4 people are expected to develop atrial fibrillation in their lifetime. Now, there's been one study analyzing this issue using National Health System databases from several Latin American countries, and this includes data from Colombia. So remember what I said about the doubling incidence with each decade of life. In the 40 to 49-year-olds, the incidence is very low, and it still is low in those who are 50 to 59 years. But see how with each decade after that, what one sees is an increasing in the numbers to about 8% in those greater than equal to 80 years of age, as I had shown you in the previous slide. And also remember that statistic of a 1 to 2% prevalence in the population. That is exactly what you are seeing here in Colombia, a prevalence of about 1.59%. Now let's begin with a case. This is a fictitious case involving Ms. A.B., a 90-year-old woman who's referred by her family doctor because she's been having some occasional fluttering in the chest, and she presents along with her son. She has several comorbidities, including longstanding hypertension and diabetes. You do a physical examination. She's small. Her blood pressure is well controlled. She has an irregular pulse of 102 beats per minute, but there's nothing otherwise unremarkable. You do an electrocardiogram. Atrial fibrillation is seen at a rate of about 98 beats per minute. It's got some mild nonspecific STT changes. An echocardiogram has been performed and shows left ventricular size and systolic function to be normal. There is some moderate left ventricular thickening, and there's also marked left atrial dilatation. You have arranged for blood work to be done. She has a normal hemoglobin and platelet count. Her creatinine is 70 micromoles per liter, and the creatinine clearance is normal at 69 mils per minute. And you want to start her on stroke prevention therapy regardless of her age, but she is 90 years old after all, and so is this reasonable? Well, as I showed you before, you do have this increased prevalence with age, but this particular study looked all the way out to 100 years of age, and what you see is that the curves do not attenuate, they continue to go up. And so as we age, and the largest growing demographic in my country, in Canada, are patients over the age of 100 years. We are going to be seeing more and more of these patients, and to the extent that we will be seeing more elderly patients with atrial fibrillation. Now, what about atrial fibrillation and stroke, which is the reason why I'm here speaking to you today? Atrial fibrillation is an independent risk factor for stroke, increasing the risk of stroke by about 5-fold. It accounts for anywhere from 15 to 30% of all strokes, and it is the leading cause of embolic stroke in particular. Now, the risk of stroke in atrial fibrillation patients increases sharply with age. It's about 1.5% in patients in my age group, 50 to 59 years of age, but it rises to as high as 23.5% in patients 80 to 89 years of age. The proportion of strokes associated with atrial fibrillation also increases with age. It's about 6.7% in those aged 50 to 59 years. Now, here's some historical data with regards to warfarin prescribing trends for patients with atrial fibrillation and a CHAD score greater or equal to 2. And as I've told you, looking at the green line here, stroke risk per 1,000 patient years increases as we age. And yet, also as we age, the tendency is for anticoagulation to be used less and less. And in fact, where the change begins to happen is around 75 years of age, exactly the time where, if we were using the CHADS VASC score, we would be getting an extra point in terms of predicting stroke risk. So what one sees is an increasing unmet need, an increasing number of aging patients who are being put unnecessarily at risk of stroke. This is an interesting study that was conducted at Massachusetts General Hospital several years ago. And what they did was they surveyed physicians. They asked them what were reasons that they might not use VKA therapy in the patients with atrial fibrillation. These were the most common reasons that the physicians gave: prior bleeds, prior falls, advanced illness. So they later went and they abstracted the charts of these physicians to find what the actual predictors of underuse of warfarin therapy was. And one of the key predictors was age. Every 10 years, these physicians were 50% less likely to prescribe oral anticoagulant therapy. Well, here's some other more recent data. These are information from the Kaiser Permanente of Northern California registry. These were not only atrial fibrillation patients, but they were atrial fibrillations with prior stroke. And they found that the proportion of these patients that were not receiving an oral anticoagulant on discharge was high. About 17% of patients less than 65 years of age, despite the fact that they had prior stroke, were not being given oral anticoagulant therapy. And look how dramatically this increased. It went up to 38% of those 75 to 84 years of age, and was almost 70% in those greater than 80 years of age. Well, here's another study, FRAIL AF. This is a Canadian study of patients greater than or equal to 80 years. And they found that about a third overall were not receiving oral anticoagulant therapy. And when they focused specifically on the severely frail patients, these were almost 3.5 times less likely to receive oral anticoagulant therapy than the patients with no or only moderate frailty. Well, maybe that's just California and maybe that's just Canada. Well, here's a third study. This is from the Veterans Affairs Boston Healthcare System. And what they found was a 14% reduction in warfarin use with each advancing decade of life. Here's an interesting European study that examined the issue of thromboembolic and major bleeding event risks in the elderly, the PREFER MAF study, or Prevention of Thromboembolic Events European Registry in Atrial Fibrillation. They examined patients less than 85 years of age and those greater than 85 years of age. In terms of thromboembolic events, the patients younger than 85 years of age on no oral anticoagulants had a slightly higher event rate by comparison to those on no oral anticoagulants. But see how much greater the difference was in those patients over age 85 years. And in the graph, when one compares the annual incidence of stroke, TIA, and systemic embolism, there isn't a lot of difference among patients given antiplatelet or no therapy versus those receiving anticoagulant therapy up until you got to 85 years of age. And what one sees there is a beginning of separation of the curves that continues such that what one sees again is avoidable harm with undertreatment. Now, the investigators also took a look at major bleeding events because in theory, if there is a reluctance to prescribe oral anticoagulants in the elderly patients, it is because of concern around bleeding risk. And again, what one sees in the patients lower than 85 years of age, slight increase, interestingly, in the patients on no oral anticoagulants, but no significant difference. However, when one looks at the patients over 85 years of age, one again sees no difference. And when one looks at major bleeding on the graph in terms of increasing age, what one sees is around 85 years, yes, bleeding risk goes up, but it doesn't appreciably differ between patients on anticoagulant and those on antiplatelet or no therapy at all. So in other words, in patients over the 85 years of age, if you're not giving them anticoagulant therapy because you were worried about bleeding, then you're not accomplishing anything other than to put them at additional stroke risk. These investigators went further. They took a look at what the net clinical benefit was adjusted for mortality risk in the overall population in this registry. And when they took a look at patients on oral anticoagulants versus those who are not on oral anticoagulants, they saw a steady decrease in events defined as ischemic stroke, systemic embolism, myocardial infarction, hemorrhagic stroke, or major bleeding with patients on oral anticoagulants. But take a look. The benefit increased as age increased such that the absolute greatest benefit by quite a bit was seen in patients who were the oldest of the old, those 90 years of age and older. So you've convinced the patient and her son about the benefits of anticoagulants in terms of stroke prevention, but the son is nervous about the potential risks. He says, I appreciate that you're trying to help my mother, but she's lived these many years without suffering a stroke. Her major problem now is that she falls often. Shouldn't that be of concern with such treatment? And the question is, should this change your mind about prescribing an oral anticoagulant? Now let's come back to that study from the Massachusetts General Hospital. Remember, They had surveyed the physicians as to reasons why they may not have prescribed warfarin therapy, and about 3.3% of the physicians said that this was because they were concerned about falls. And when they went and they did chart abstraction, what they actually found was that patients with a history of falling were 5.5 times less likely to be prescribed vitamin K antagonists. In fact, history of falling was a greater reason for not treating than patients who had a history of hemorrhage, of advanced malignancy, of prior ischemic stroke. The only thing that was a greater inducement not to provide oral anticoagulant therapy, or in this case warfarin, was cognitive impairment. Should falling be an issue? This was a study taking a look at time to first major bleeding according to risk of falls among patients who were all receiving oral anticoagulant therapy. And when they looked out over a year at patients at high risk of falls and those at low risk of falls, the risk of major bleeding was exactly the same. A Canadian study published 2 decades ago suggested that for the calculated risk of a subdural hematoma from falling to outweigh the stroke reduction benefit of warfarin, a patient with a CHADS score of 2, 6% annual stroke risk from atrial fibrillation would need to fall almost 300 times in a year. Remember that when elderly people fall, they tend to fall by tripping, from getting too quickly out of a chair. They will scuff their knees, they will bruise. Very few elderly patients are going to go tumbling down a flight of stairs. And I would submit to you that a younger patient on anticoagulant falling down a flight of stairs is probably just as likely to develop a subdural hematoma than an older one. So I would propose to you that risk of falls is not an adequate reason to avoid oral anticoagulation. So you tell the patient that you will prescribe her a new blood thinner that is at least as safe and effective as warfarin at preventing strokes, but is much easier to use. And her son says, listen, I understand that warfarin is not perfect, but it's been around a long time. The drugs that you're speaking about have only been around for a few years. What assurance can you give us that they will work as well as you say they should? So what reassurance can you provide the son? Well, if we take a look at the 4 phase 3 trials that assessed all of the non-VK oral anticoagulants that are currently on the market, what one sees is that if you use 75 years of age as a cut point, anywhere from 1/3 to over 40% of the patients in these studies were elderly. And they weren't just elderly, these were patients who had a high degree of comorbidity. Heart failure, anywhere from 25 to almost 60%. Hypertension, anywhere from 3/4 to over 90%. Diabetes, anywhere from 20 to over 33%. Prior stroke, TIA, or systemic embolism, from a low of 19% to over 41% in the ROCKET-AF patients. And so when you take a look at the overall mean CHADS score, anywhere from 2.1 to 3.5 in the patients overall, but higher, anywhere from 2.7 to 3.7 in the older patients. How did the older patients do? These are results from Christian Ruff's meta-analysis in The Lancet, pulling the data on all the non-VK anticoagulants and comparing them to warfarin. And when he used 75 years as a cut point, what one sees is that the elderly patients achieved similar benefit as the patients younger than 75 years of age. And in each instance, there was statistically significant benefit as compared to warfarin. When he then looked at major bleeding events, again using 75 years as the cut point, what one sees is that there was no difference between the older and younger patients, and in each instance, they tended to, or statistically significantly did, better than warfarin in terms of having fewer major bleeding events. Let's come back to the PREFER-NAF study. In this instance, they looked specifically at patients greater or equal to 75 years, as had been done in the rough meta-analysis. And when they looked at the composite of major bleeding and ischemic cardiovascular events, it was lower in those age greater 75 years or older on a non-BK anticoagulant versus warfarin. And when they independently assessed major bleeding and ischemic cardiovascular events, again, the rates were lower in these older patients on a non-BK oral anticoagulant as opposed to those on warfarin. And in each instance, the difference was statistically significant. So in other words, findings from the real world absolutely parallel what we had seen in the phase 3 studies. Now, PREFER-AF went further. What they did was they analyzed the individual compounds that were in the marketplace to any sufficient degree that they could do analyses. Rivaroxaban, dabigatran, and apixaban. Edoxaban was still new to market. And what they found was that all of the drugs uniformly did better in terms of having fewer major bleeding and ischemic cardiovascular events as compared to vitamin K antagonists. And indeed, with rivaroxaban, the difference was actually statistically significant. Here's another recent study, a French study, the bleeding risk in elderly subjects aged more than 80 years in atrial fibrillation treated with rivaroxaban anticoagulant, the SAPPHIRE-AC, in which they took patients greater than 80 years of age with non-valvular atrial fibrillation from 33 geriatric settings across France and followed them out for 12 months. The patients were elderly, 25% over 90 years of age, and their CHA2DS2-VASc scores were high, means of over 4.5. They took a look and compared rivaroxaban to vitamin K antagonists and whether they analyzed major bleeding, intracerebral hemorrhage, stroke, or mortality. In each instance, rivaroxaban was favored. In terms of major bleeding and intracerebral hemorrhage, interestingly, rivaroxaban was statistically significantly better than vitamin K antagonist. And for mortality, there was almost a statistically significant benefit. When they looked at how the events changed over time, what they found was that there was a non-significant difference in regards to stroke, although there was some separation of the curves. And who knows how it would have proceeded had they been able to follow the patients longer than 12 months. But take a look at major bleeding. Right from the outset, the curves began to separate, and they just separated more and more over time. So again, major bleeding should not be a concern. Here's another study. This is a detailed slide. All I will say is take a look at this first graphic, risk of stroke and TIA. In the top portion, you have a series of real-world studies. In the bottom portion, randomized controlled trials. And what you see is very consistently, whether it's the randomized controlled trials or the real world, one sees a clear benefit in favor of the non-BK oral anticoagulants by comparison to warfarin that overall is statistically significant. And when one looks at risk of major bleeding, again, real-world studies on the top, randomized controlled trials on the bottom, one sees at least a tendency towards fewer major bleeds with the non-BKA oral anticoagulants by comparison to warfarin. There was a statistical difference in the randomized controlled trials, not quite statistically significant, but trending very strongly in the real world. Here's another very interesting study that relates specifically to our case. In Taiwan, they have a national health insurance database that contains information on all patients in the country. And these investigators took a look at over 26,000 patients with atrial fibrillation greater or equal to 90 years of age. And in the first instance here, they analyzed in the pre-NOAC era, 1996 to 2011, patients on no antithrombotic therapy in the black, the dotted line being the comparator, and then compared those who were on antiplatelet drugs in red and those on warfarin in the blue. And what one sees is when they analyze ischemic stroke, there is a trend for benefit with warfarin by comparison to antiplatelet therapy, although this was not statistically significant. Interestingly, when they took a look at intracranial hemorrhage, again, no statistically significant difference between those on warfarin and those on antiplatelet agents, but the trend is going in the wrong way. They then took a look at patients in the post-NOAC era, 2012 to 2015. In this instance, warfarin still in the blue, but now the NOACs in the green. NOACs and warfarin were similarly efficacious with regards to stroke prevention. There was no difference in terms of major bleeding, but take a look at the marked difference between the NOACs and warfarin in regards to intracranial hemorrhage. A clear and stark reduction in this very frightening event with the newer drugs as compared to vitamin K antagonist. So now as you go to complete the prescription, you pause for a moment and consider ordering a lower NOAC dose than you might normally do, because you still do have, despite the information that I provided to you, a nagging concern about bleeding. And the question is this reasonable? Well, here's some interesting studies. First of all, let's go back to warfarin. Even where warfarin has been used, its therapeutic effect has tended to be suboptimal. There was a very recent study published in 2014 across 4 European countries, and at that time, the number of patients in therapeutic range, when we keep the bar awfully low at 70%, was only achieved in just over 47% of patients in France, just over 44% in Germany, 46% in Italy, and the United Kingdom was a little bit better, but even there it was only 65%. Well, maybe we're doing better with the NOACs. Well, we are doing somewhat better, but the prescribing pattern is still not optimal. Of just over 5,700 patients with a mean age of 71 years who were on an oral anticoagulant in the ORBIT-AF2 registry, 9.4% were underdosed, and this was especially prevalent in those who were older. Data from a US administrative database of over 14,000 atrial fibrillation patients started on a non-BKA anticoagulant showed that over 13% were potentially underdosed. And another American retrospective claims database analysis found that more than 40% of patients over the age of 80 years of age were receiving an inappropriately low dose of NOAC. This is a very interesting study by Yao and colleagues that examined 13,392 American patients with atrial fibrillation and no renal indication for a reduction in dose. And what one sees again is the older the patients get, the more likely they're going to be underdosed. And there is a marked difference when all of a sudden patients turn 80 years of age and older. This is not good for any of the drugs, but it appears to be especially prevalent in regards to apixaban. Well, does this come at a cost? Well, it absolutely does. If you take a look and you pool the data across all of the non-BK oral anticoagulants considered in this study, apixaban, dabigatran, and rivaroxaban, there was actually a price to be paid, not just in terms of stroke and systemic embolism by underdosing, but interestingly also in regards to major bleeding, which is counterintuitive. But then they looked further and they found that in fact, the concern, while it is there, appears to be more so with one of the NOACs, apixaban, than it is with the other two. This is a very recent study. It was just published a few days ago in the Journal of the American College of Cardiology. And this was from the Garfield Registry. And they took a look at all-cause mortality, stroke, systemic embolism, and major bleeding as a function of whether patients were on non-recommended low dosing, non-recommended high dosing, or non-recommended dosing overall. And what one sees is that there is a price to be paid in terms of stroke and systemic embolism, with especially underdosing being associated with more events, although this was not statistically significant. There were somewhat fewer major bleeds with non-recommended low dosing, but again, overall, differences across the group, not statistically significant. But take a look at all-cause mortality. When they took a look at unadjusted and adjusted non-recommended dosing, the trend was clearly towards paying a price in terms of all-cause mortality, and this, in fact, was statistically significantly so even after adjustment in the patients who had non-recommended low dosing provided to them. Interestingly also, they took a look at various subgroups: women, patients according to age, ethnicity, weight, history of acute coronary syndrome, vascular disease, prior stroke, diabetes, extent of chronic kidney disease, and concomitant antiplatelet therapy. And take a look at patients in the Garfield Registry who were Hispanic and Latino. They had especially increased risk of an adverse event if the NOAC that was being prescribed was being inappropriately given at too low a dose. So you finally finish writing your prescription, hand it to the patient, having selected the higher dose of any of the factor Xa inhibitors of your choice, or the lowest dose of dabigatran. And the question is, why the difference in dosing strength between the various types of non-BK oral anticoagulants? The reason why comes down to this sub-study of the RELY study. Remember, in the RELY study, you were randomized either to warfarin, 110 milligrams of dabigatran, or 150 milligrams of dabigatran. No other considerations were given. Neither what your age was, what your sex was, what your renal function was. It was solely randomization according to dose of drug in the case of dabigatran or warfarin. When they looked afterwards, the only interaction with drug dosing was age. Patients less than 65 years of age had fewer major bleeding events with either the 110 or the 150 milligram dose of dabigatran by comparison to warfarin. There continued to be fewer events in the 65 to 74 year age group, although it began to trend in the wrong direction. In patients who were older than 75 years of age, the 110 milligram dose of dabigatran was now associated with as many major bleeding events as was warfarin, but the 150 milligram dose was now associated with a greater number of major bleeding events. And as a result of this, product monographs stipulate that the 150 milligram dose of dabigatran should absolutely be avoided in patients over the age of 80 years of age, like our patient. And we would also suggest to you that you consider avoiding it in patients greater than 75 years of age, especially when the thromboembolic risk is low and the bleeding risk is high. For either apixaban, edoxaban, or rivaroxaban, the factor Xa inhibitors, efficacy against stroke and safety for avoiding major hemorrhage is not significantly different between patients using either the 75-year cut point. And so when one looks at the dosing algorithms, this is for dabigatran, our patient had a creatinine clearance of 68, but she was over the age of 80. And so the only option for her is the 110 milligrams twice daily dose of dabigatran. Had we decided to use apixaban, she was over the age of 80, but she was not less than 60 kilos. Her serum creatinine was not over 133. So she only had one of the features that might affect dosing change. And as a result, she would go on the 5 milligram twice a day dose. For her to default to the 2.5 milligrams, she would have had 2 of 3. For rivaroxaban, it's fairly straightforward. You don't have to consider age or anything else. You just take a look at renal function. Again, her creatinine clearance was 68, and so she would go automatically on the higher rivaroxaban dose, 20 milligrams once daily. So as the patient and her son are about to leave the clinic room, you remember to tell her about the importance of taking her medication as prescribed. So why is this important? Well, I would submit to you it's important for any drug. If we're going to write a prescription to a patient, we're going to want them to take it and use it as prescribed in order to get the benefit that we intend that they have. This is a very interesting study. It was a survey of consecutive outpatients with atrial fibrillation who had been referred to Italian centers that specialize in thrombosis management in 2017. They looked at a series of variables to see what predicted inappropriate adherence specifically to the non-BK oral anticoagulants in elderly patients. And the only thing that predicted inappropriate adherence was double daily duration. Even cognitive decline, even polypharmacotherapy did not predict inappropriate adherence. Patients do, in fact, generally favor a once daily over a twice daily regimen of any drug. This was a European survey that specifically examined patients with atrial fibrillation. And they asked them, would you prefer once daily dosing, twice daily dosing, or were you not sure? And there were some people who declined to answer. And when they took a look across the several countries, what they found was 81% overall said that they would want a once daily anticoagulant. This is another way to take a look at it. So it's not only a problem with whether you take the drug or not, it's whether you're taking it the way you're supposed to. This was a Canadian study. It was a survey. They asked patients, how often are you taking your drugs once a day versus twice a day? And for apixaban and dabigatran, almost 1/3 of the time, patients were taking them only once a day. When they looked at rivaroxaban and warfarin, it wasn't perfect, but 90 to 95% of the time, the patients were taking these drugs as prescribed. Now, even with the novel anticoagulants, persistence over time is poor. In this instance, a study from the United States, Craig Coleman analyzed warfarin, dabigatran, and rivaroxaban, and yes, the once-a-day drug did show less drop-off over time, but still, over 2 years, the number of patients who were persisting with their therapy dropped from about 80% down to about 50%. What this tells us is that every time one sees a patient, whatever the drug is, but especially a drug that is meant to prevent an event as consequential as an ischemic stroke, we should be reminding the patient, we should be asking them, are you taking your medications? And if so, why not? This was an interesting study that had nothing to do with anticoagulant therapy. This was the CHARISMA trial that took a look at whether clopidogrel should be used as preventative therapy in patients at high atherothrombotic risk. And when the trial was performed, they looked afterwards at the 5 greatest predictors of cardiovascular mortality. Sure, history of heart failure, previous MI, and so forth predicted a greater risk of death. But the one that showed the greatest predictive ability was permanent discontinuation of study drug. If you're not going to use the drug that is going to protect you against an adverse event, then you have a higher likelihood, of course, of sustaining that event. So let me just wrap up. I hope I've shown you that risk of atrial fibrillation increases together with increasing age, and given the fact that we have aging societies worldwide, the global prevalence of atrial fibrillation is going to double or triple even over the course of the next generation. Older patients have the greater risk of preventable stroke attributable to atrial fibrillation, and yet the elderly have been those that have tended least to be treated with effective antithrombotic therapy. There's no question warfarin is safe and effective for stroke prevention in the elderly, but the NOACs are better still, and this has been shown both in phase 3 and real-world studies. Even when oral anticoagulants and the non-BK oral anticoagulants in particular are administered to the elderly, too often they tend to be underdosed. And when this happens, they're going to result in reduced efficacy and, more often than not, little difference in safety as compared to appropriate dosing. While bleeding risk in the elderly is a concern, both its absolute and relative extent have been, in my view, overestimated and overemphasized. Finally, real-world studies, again, I hope I have shown you, consistently support use of the non-BK oral anticoagulants, prescribed according to their dosing algorithms, and even the oldest patients with atrial fibrillation who have relatively the most to gain or to lose. In fact, I'll let you in on a little secret. The fictitious patient there is very close to my mother, who is going to turn 95 years of age in November. She has a history of arterial thromboembolism. She is receiving rivaroxaban, and she is receiving it at the 20 milligram daily dose. Finally, I just want to point out that we do now have updated atrial fibrillation guidelines from the European Society of Cardiology, and they're available online. And in another month, my country, through the Canadian Cardiovascular Society, will be releasing our atrial fibrillation guidelines. That's the end of this talk, and thank you very much for having listened to me.